Our next speaker comes from Colombia, Cali, Colombia, South America. Dr. Carlos Ordóñez is the chief of the Division of Trauma, Surgery, Acute Care Surgery, and Critical Care. He has pioneered the resuscitation and trauma surgery in Latin America. He's the immediate past president for the Pan American Trauma Society, and we're incredibly honored to have him here today.
This is our hospital, picture of our hospital in Cali, Colombia. And I would like to take this opportunity to invite all of you to the Pan American Congress of the Trauma Society that is going to be held by the end of November and December the 1st in the city of Mexico. We're going to talk about REBOA for penetrating torso injuries. Always, and in all the articles and publication, you see the phrase, stop the bleeding. And we have to stop it. But is it actually stopping the bleeding or stopping the bleeding on time? It is not a simple word. So we have to understand several things. The new concepts, the non-compressible torso hemorrhage, NCTH, by the acronym, and the NCTH is the large pulmonary vessels and the large chest vessels, the large vessels of the abdominal cavity and the solid organs. And why is it important? Because having this type of injury may provoke some serious matters, because the pulmonary vessels or the large vessels may be affected by 53%, like other torso vessels, and then 25 to 30% of the solid organ may be injured, and that's what creates the serious problems. And see here, over 2 years in the National Trauma Data Bank, we have 249,000 non-compressible torso injuries. We have to differentiate between an injury and a hemorrhage. Of those injuries, non-compressible torso injuries, over 20,000 are those provoking non-compressible torso hemorrhage. And what is the difference between those two? The mortality by torso injury is 6%, but the mortality from a hemorrhage of those injuries is nearly 50%. And of those hemorrhages, if you're able to stop the bleeding on time, they could be prevented. So that is the idea. How from that 45% of mortality in the NCT hemorrhage, we can lower that mortality if we're able to stop the bleeding. So what is the real challenge? And we have patients with those injuries, multiple injuries by gunfire, and that is a real challenge for a surgeon. Earlier they talked about the golden hour, and definitely the golden hour is very important, but it is not the hour, it is those platinum 10 minutes. That's the new thing, and the soldiers in Iraq are talking about that, and the paramedics, and we think that those platinum 10 minutes should be used in the emergency services. When we meet a patient, those are the first 10 to 15 minutes where we need to approach the patient and make clear-cut decisions instead of waiting for 1 hour. So with those patients, I mean, is it that all of them require surgery? And if they do, does it have to be thoracotomy, resuscitation, or paracotomy? Because those are the emergency surgeries. Do they require that, all of them? So let's look at the different scenarios and how we break them down so that we can better understand this. Scenario one, that is a patient that is really unstable with an SBP equal to 60 or 70 or under cardiac arrest. That patient possibly is going to require surgery immediately, or in some cases we may take the patient to hemodynamics, and if we have a hybrid room, this would be the ideal situation. But now, we are going to retake that later, but there is another scenario of the unstable patient with an SBP around 80, less than 90, tachycardic, and a young patient of 20, 30 years old. And we know the definition of a shock. If you have a systolic under 90, you have lost 1,500 or 2 liters of blood. So it is actually in shock, in a grade 3 shock. So we have a systolic of 80, that would be very serious. But we may have to several things. If you have a trauma team that is fully trained and they know what to do, then you may identify a serious patient like this with multiple shotguns on the chest and the abdomen, and you have to make a decision on how to operate this patient on the chest, on the right or left subclavian, on the heart, the abdomen, where. So we need to have clarity about that. So what we do, the patient arrives immediately, we start working on the airways, on the vascular access, and this is one of the things that we're doing today, the echo, the ultrasound, and they're having 2 echoes at the same time here, 2 ultrasounds. But the thing that is a priority, because the ultrasound is going to let us know very fast where the patient is bleeding in the pericardic or the pleural or the lung or the abdomen areas, that is in the right or the left cavity. So in less than 1 minute you can have a better idea. And then the next step, to that group of patients that are unstable moderately, we have those catheters. That is a kit that we have already prepared, and it includes a venous high flow catheter and a thin catheter to be placed in the artery. The emergency doctor that is highly trained in handling the ultrasound places this patient with a 80 systolic or 70 or 90 blood pressure, a catheter that is large in the femoral vein that is going to serve to place the blood, the different blood products, the plasma and the contrast, if we have to take this patient to the CT scan, and then a smaller catheter that is going to be helpful for 2 things: to measure the blood pressure and take the gases, and also as a guide if in the future we require a REBOA catheter. So those are the 2 catheters, and then we measure time and what to do. An emergency doctor trained in the ultrasound placing those 2 catheters and let them fixed. He could take 4 minutes. So in 4 minutes we have all of those lines ready. And then we do the echo, the catheters, and also we proceed to activate the massive transfusion protocol. We're not going to spend too much time here. This is one of the latest publications. Dr. Holcomb is present here, and they say what to do. The protocol should be 1-1-1 ratio. That's what we do. We stop fighting about 1-2 or 1-1. So it is 1-1-1. And then, additionally, from this recently published article, not only the activation of the protocol, but what this paper states. If you lose every minute making a decision and starting the massive transfusion, the mortality increases 5% every minute. So we were able to prove that. This is a chart while we prepare with our patients. And notice that if we start the resuscitation in the first 15 minutes, that's a black solid line. See how mortality changed instead of starting after 45 minutes. That's where they're proving now in all the articles. So the resuscitation should be very aggressive, fast, and a 1:1:1 ratio. That's the MT protocol. Many units of every fluid. That's what Dr. Holcomb mentioned this morning. This should become a single package. So that's how we have it. We trust and we hope that in the future the whole blood can be used in most patients, but that is not the case because we have not been able to convince the lab and the blood bank people. But that is what we do, and we activate it very fast. And we also have in case we require it, the blood collector, but this is only for the red blood cells. So what happens in one of those patients? Look at all of those shotguns, and the systolic pressure is 60, 20, 60, 80. Patient could be under cardiac arrest. So what decision to make? Decisions were always a thoracotomy, resuscitation, when the patient has already lost pressure and went under cardiac arrest, or being preventive. So this is the shotgun injury, so we need to have a thoracotomy, a laparotomy, and it is true, and we have performed that, and we have performed relatively well, but mortality still high. So we will continue to perform this opening 2 cavities. We have realized that when we open 2 cavities instead of 1, the mortality is 3 times higher. If you have a laparotomy, the mortality is less than 20 or 10%, and you do the thoracotomy and damage control, is more or less the same. But if you open 2 cavities, the mortality is 45% in our cases. So is it that this is what we're supposed to do? So we don't think we should perform this any longer. And here we have a publication of Simon and Dr. Reed. When you have a resuscitation thoracotomy, that is when you're nearly in a cardiac arrest, but the survival is 7%. That is not the proper thing. So patients get there with a systolic of 60 or 70, and there's where you have to approach the patient and stop the situation from going into a cardiac arrest, because those numbers are going to grow very fast. So we have a patient like this with a shotgun injury. See how it goes through, and in a CT scan you see how the sacral is destroyed and the rectum injury. I'm going to this is a patient that is unstable, and we take it to a scan to see how to approach this patient that is critically injured. So what are the indications? We make clear decisions based on experience. We published this article 3 or 4 years ago at the Trauma Journal. It is trying to understand this ABCD when we have a patient in the operating room and we need to make a decision about resuscitation and damage control resuscitation. So, and this could be performed very fast in the first few minutes, because the anesthesiologist is going to take the gases, and if it is over 8, already by opening the cavity, we have over 1,500 centimeters of blood, or if the temperature goes below 36, you're able to establish the anatomic damage. A trauma surgeon is able to detect the damage to determine if you have to package or clamp the bowels. So if you see that in the first few minutes, you can make a very fast decision and go into resuscitation and damage control surgery. So what is the idea? To control the bleeding. So is it that by controlling the bleeding, we're going to continue doing the same thoracotomy, laparotomy, and this? So we think that is not the case. We think that we have new techniques to approach those patients, and that's why we believe right now in the endovascular REBOA technique. And as we know, for a long time since the Korean War, it was used, but over the last years, in 2013, when some groups started developing and trying to become preventive, because that's what we have to be. We need to be preventive. Patients are at 80 or 70 of systolic, so we cannot stay there thinking and let that patient bleed completely, because when you have a systolic of 80, you only have 5 or 6 minutes left to go into a cardiac arrest. So you have to make a decision at that very moment, and that is the actual control of bleeding and the way to make a difference. There are multiple articles in this regard trying to prove if it is good or not, the REBOA compared to a thoracotomy. And notice that it is the case. It is better. It is not, well, the difference is not significant, as this American article or the Japanese articles show. I mean, they match if the REBOA and the resuscitation thoracotomy are the same or not. We think that that is not the comparison. For example, this Japanese article, the same. They compare and they fare better. And if you look at the curve, it is much better for the REBOA. But is it that we have to compare when you're nearly to enter into a cardiac arrest to perform the thoracotomy or place the balloon? We think the balloon should be placed before. We perform a meta-analysis with one of our fellows and the group that we have here based on the existing articles. We have 3 good articles on REBOA, and in the meta-analysis it proved that it's better to go into the REBOA than the thoracotomy, and when we look at the sensitivity analysis, it is better. But we think that this is not the step, because we should not end up in this state, a patient with a thoracotomy, an aorta clamping, and a dead patient. So we need to do something different. So what is the idea? What is the REBOA doing? To perform the REBOA before the patient collapses, when you have lost 1 or 2 liters of blood, when your systolic pressure is under 90, the patient has a serious situation, but you need to perform this. And it consists of putting this catheter up in the femoral common artery, place it in the zone 1 of the aorta, and inflate it in that area where you have a lot of space to play. You have 20 centimeters, and with a very fast measurement, you're able to place it there. And what is the result? This is like clamping the aorta with a thoracotomy. But the idea is not only clamping the aorta, but also perfusing the brain and perfusing the heart as the surgeon reaches the control of the bleeding. If you don't think that way, that you need to perfuse the 2 most important organs and keep them working as you take your time, that it could take 20 or some minutes to control the bleeding. So you need to have a perfusion of those vital organs to achieve that. And those are the 2 areas on how to measure the aorta. So see that in the zone 1 you have 20 centimeters. So we measure from the clavicle to the femoral, and you have to play. And there are several measurements. So do not be afraid that you need to have an imaging or a CT scan or an ultrasound to determine where the balloon is. That doesn't have a major issue. So you measure between 50 and 60 centimeters, you're able to place the balloon in zone 1, and in 20 and 30 you're able to put it in zone 3, and you know that, and you can do it very fast. But there are many details, and you need to learn many things. It's not just to place it there and that's it. You need to take the courses, you need to know how to inflate, how to deflate, or when to deflate, because you have different risks and complications. You need to be trained for that. But people could get that training. So I am not saying that you need to place it on your own. You need to have a proper training, that's what I mean, and you are able to take that training. I had a video here. I don't know how to play it. Is it possible to play the video? It was supposed to be a video trying to show how you place it and see. At the same time, there's a group of surgeons that is placing, see? So here we're measuring, we measure. So we use this balloon, that's the one we have, the Cook balloon. So we measure, we mark, because we don't have any marks here in the catheter. So we place it here, and that is going to give us the 55 centimeters. See that the patient had the two catheters already in place, and at the same time another surgeon is opening the sternum. So we have two teams working at the same time, and that facilitates things. So you can choose. You may go into the resuscitation thoracotomy or clamping the aorta in the abdomen. Some people say it's easy, others consider that very difficult in a multiple injury, or to have an endovascular occlusion. Some information of our experience: we have already placed the balloon. In some cases, we have 7 cases here with a gunshot injury in the abdomen. The patients arrive with a systolic of 60, and after placing the balloon, it goes up to 130. The hemorrhage of the laparotomy was over 2 liters, and the procedure time 4 minutes. So this chart, those are the different injuries of those patients, and see here in the third column of the systolic, all of them had 60, 70, 50, 55, 40 of systolic, and then it went up after the balloon, after 4 minutes. So let me show you a case that it is not only blunt trauma, but a very interesting case with a different approach. It is a young patient, 16 years old, with a motorbike accident, with a systolic of 100 and a heart rate of 110, positive fast. And in another hospital, the CT scan showed liver laceration of 10 centimeters in segments 4 and 8, and with an active bleeding of the right hepatic artery. So they refer the patient to us. We know that there is a CT scan, so immediately we take him to the angiogram, and then you see a branch of the right hepatic artery bleeding. We embolize, we place the course, and we stop the bleeding of the right hepatic artery. But the patient is still unstable, distended, and we decided to perform what they mentioned this morning, the hepatic bleeding control. But how we understand this? We don't have to operate and clamp the vena cava below the heart. That's too difficult for the surgeon to perform. With the bleeding of 3-4 liters in the suprahepatic artery, I don't think we're going to be able to insulate the hepatic area without having the patient die. So I think we need to perform something different. And this is different. This is a hepatic isolation, REBOA. And then we placed another balloon on the femoral in the liver that is controlling the bleeding of the suprahepatic artery and the superior vena cava. And when you operate, you do the Pringle, and then you have the hepatic isolation, and you can operate then. Those are the hepatic lacerations, and see, circle the venous injury that is different to operate when you have already clamped the aorta and the vena cava. Because as you evacuate the 4 liters from the abdominal cavity and the patient continues to bleed, you are not able to perform that. But if you have that hepatic endovascular isolation, you're able to perform that. And then we have also performed the following. That's a new thing. If you have chest complicated injuries, multiple injuries in the pulmonary ileum and the chest, what are you going to do? So with those injuries, thoracotomy, clamshell, or all of those approaches as described in the literature. So the surgeon is overwhelmed and doesn't know how to approach these patients, and it is difficult. It takes time to open the patient and to reach that area. If you have an injury on the right subclavicle side and you approach with the left thoracotomy, how are you going to control that? So you need to make a different decision. And the patient has a systolic of 70, 80, so what to do? Because if we do not perform the opposite, we're going to be like this. That's a picture of a patient operated with a laparotomy and a lateral thoracotomy, but the patient is there and the patient is going to die. So we need to do something different. So this is an article from South Africa, from Nazaria, how to approach the subclavian artery. And they're quite clear that the approach of both subclavian arteries, right and left, we have had difficulties in approaching those subclavian artery injuries. The best way is through an sternotomy. So, what to do? Our proposal and what we have done in those patients is the following. If you place a balloon, listen carefully. If you place a balloon in the aorta, right there, people think that the flow may be lost through the broken subclavian. So what we intend to do is to restore the flow to the brain and then to resuscitate both the heart and the brain while you're approaching it. And we're going to show this abstract in September in the American Association of Trauma Congress, and our proposal is to combine the REBOA, the balloon, with a median sternotomy for the complicated injuries of the chest. So if you have this injury in the right subclavian, you may place a balloon, folic probe, as the patient has it in place over the injury, or in a surgery as you start, and then you inflate it, and that way you may try to control the bleeding, or at least or prevent it. So we do a median sternotomy, right, left, if we suspect a pulmonary ileum. So the surgeon doesn't have to start thinking, do I perform a right, left sternotomy, thoracotomy? So we want to avoid that and have an ideal approach. So to those complicated injuries, you do the sternotomy, you place the balloon at the same time. One group is placing the balloon and the other group is performing the sternotomy. And the patients are as complicated and as serious that possibly all of them should remain like that, with the chest open, packaged. And 48 hours later, you take that patient back to surgery, you remove the bandage, you remove the bag, and you close the sternum and the skin, and the patient is going to end up like this. So what is the idea? If you have a wound like that, you're going to clamp the aorta with the balloon. You have the injury in that area, in the subclavian, in the red line. You may have bleeding, and you may have an increase in the flow, but you're trying to do something by using a Foley probe or your finger and see that the flow goes to different parts. By clamping the aorta, the flow not only goes through the whole of the wound, the flow may have other options to move to the carotid, to the subclavian, or to the heart. So the idea is clamping the aorta. It is what we do with the resuscitation thoracotomy. When you have a chest serious injury, you do the thoracotomy, you clamp the aorta, and then you approach the injury. So this is the same, but you don't perform the thoracotomy, you only clamp the aorta with the REBOA, then you perform the sternotomy, and then you approach the injury. So that could give you time to reach such a complicated injury, because this could take more than 2 minutes. You need to open the chest, the sternum, you need to identify it and then reach it. So you need to take your time, and the only way to take that time is by perfusing the heart and the brain. And this is a chart showing what we do with those patients. You place the balloon, then you have the injury here, you place another balloon, and as time goes by, you perform the sternotomy and the prolongation to any side. If it is through the carotid, through the neck, and the patients end up like this. 48 hours later, you close, and you don't have any issues. Or that way you extend it to one side or the other. That is the experience of the last 2 years. 30 patients with REBOA, 8 patients with a blunt trauma, 22 patients with a penetrating trauma. Their mortality is 26%. We have complications, 3 related to groin access, damage in the artery or a thrombus in the artery. You need to be very careful, and you can repair that immediately, or you can use a Fogarty and embolize the artery. So you need to detect and know what could happen. And we have 2 systemic complications with a GI bleeding, a patient that was for 60 minutes with the balloon inflated, and a patient with ischemia in a serious trauma. So we may have systemic and artery-related complications. Here, this is the new balloon, the ER REBOA of the Americans, different from Cook with a 7 French. It is very well marked, it can be easily placed, and it can prevent more injuries in the artery. Maybe not the systemic injuries or complication, but that's the progress that we have achieved so far. And there are different ways to study and practice, because you need to practice, you need to study. We have used cadaveric models, and we think that they need to take every possible course. And this is another balloon, the competition of the American balloon, the Japanese balloon. That is an ideal balloon. It is also a 7 French. It has a protector like the Swan gun protector. It also has the marks. It is a very good one, and it also has a training model. So we have valid options from the US and from Japan. Now we need to see what we're able to implement so that we can have a cost-effective situation, because definitely we think that the balloons should become smaller. So what is the current situation? That you need to be more aggressive in your strategies and your bleeding control techniques. And bleeding control is not something that can be easily achieved. Are we going to continue with the thoracotomy, open to cavities, or we perform the new option that if people are trained and they do things in a different way, we're going to be able to have better techniques to improve the survival of our patient. And we believe in this phrase: if you want different results, do not do the same things. So we invite all of you to change. Thank you very much.